அட்டன் பண்ணலையா அப்போ? Good afternoon, everyone present here. I, Dr. Megha Satyavali, welcome you to the lecture series on cognitive rehabilitation organized by MGOTC. I would like to call upon Dr. S.K. Meena sir, Principal Mahatma Gandhi Occupational Therapy College, to address the gathering. Welcome, sir.
Yes, good afternoon to all. I take this opportunity to welcome and address to all on behalf of Mahatma Gandhi Occupational Therapy College, a constituent college of Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. The initiative of this lecture series is the starting of new journey our esteemed faculty is giving to talk the session. I am sure that you will have a wonderful time learning new things. In future, there will be more series and new programs and fellowship that will be offered by Mahatma Gandhi Occupational Therapy College in association with Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. I hope to see all in the future gathering. Thank you very much.
Thank you, sir, for your kind words. So without any further ado, I would like to introduce our speaker for the series, that is Dr. Agrima Agarwal. She has done her bachelor's from IPH and master's from Nirtar. She has experience in working with different neurological conditions, and her keen interest in research and development has contributed in multiple research backgrounds. Welcome, Agrima.
Hello everyone. And think, learn, and do, execute is a Hello everyone. My name is Dr. Agrima Agarwal. I'm working as assistant professor at Mahatma Gandhi Occupational Therapy College. And the topic for today's lecture is cognitive screening and its impact on occupational performance. So let us start with what is cognition. Cognition refers to the integrated functions of the human mind together resulting in thought and directed action. Anything that we are doing, we are thinking, learning, or doing is a part of cognitive process. It is the product of many integrated processes carried out by the brain that allows us to be aware, think, learn, judge, plan, and execute behavior. What are the primary cognitive capacities? So the cognitive components are divided into 3 levels. First is primary cognitive abilities, second is higher level thinking abilities, and the third is meta processes. We will be looking into details in all these components. So now the primary cognitive capacities, these reflects the neuroanatomical and neurophysiological integrity of the brain. So the first component that we have to assess while we are assessing the cognition is the primary cognitive capacities, which includes 3 components: orientation, attention, and memory. Now, second level is higher level thinking abilities. These abilities are dependent again on the primary cognitive capacities. For the higher level thinking abilities, our primary capacities should be intact. And these are the result of the dynamic interaction among the various parts of the brain. Now, the last, meta processes. Meta processes are facilitated by both primary cognitive capacities and higher level thinking abilities. So higher level thinking abilities are reasoning, concept formation, and problem solving, while meta processes includes executive functions and self-awareness. We will be looking into detail among all these. Now, first is primary cognitive capacities, in which the first is orientation. Orientation is awareness of self in relation to person, place, time, and circumstance, where we will ask the patient whether he is aware of where he has come, who he has come with, or what is the time, what is the date, what is the day, year, or what is the season. That means the patient is aware of the orientation. Next, second component, primary cognitive capacity, is attention. The attention term was coined by William James, and he defined attention as taking possession by the mind in a clear and vivid form of one out of what seems several simultaneously present objects or trains of thought. That means we are looking at a clear thought process where we have to simultaneously process all the surroundings and the trains of thoughts that are going on and focus on the task that we are doing. Now, deployment of the mental resources for concentration. Attention is primarily required for concentration to be focused on. Attention abilities are dependent on multiple brain regions like cingulate cortex, limbic system, prefrontal cortices, and sensory motor regions. Now, the types of attention. We have Solberg and Marty divided types of attention into basic 4 types of attention. The focused attention is a part of concentration. So we have main 4 types of attention, that is sustained attention, selective attention, alternating attention, and divided attention. Now, what is focused attention? The focused attention is the basic response to a stimulus. That means whenever someone is asking you something and you respond to that stimulus, that is your focused attention. That you got a stimulus and you responded to it. That is focused attention. Now, second is sustained attention. It is also called vigilance. It is maintaining the attention over the time during the continuous activity. Like, for example, right now we all are looking at this, all of you are looking at the screen and continuously listening to what I am saying and also focusing on what is mentioned on the screen. So this is sustained attention. We are giving a constant attention to a continuous activity. The third type of attention is selective attention. It is the ability to focus attention in the presence of a distracting stimuli. That is freedom from distractibility. So in case of the selective attention, what we are focusing on is the tasks that we are performing, even in the presence of distractions. Like, for example, right now, so many people are attending the meetings. Some maybe are in the clinic, some are in the classroom, or some maybe are at home. So there is something in the background that is going on, and everyone is distracting everyone are ignoring the distractions in the background and focusing on the presentation right now. So that is selective attention. Alternating attention. It is the capacity for mental flexibility. That is our ability to shift our attention from one task to other. That is between multiple operations. Now in alternating attentions, we are shifting our attention from one task to another. Like for example, if you are listening to the screen right now and you are also in the clinic, you have to also focus on the clinical demands that you have at your workplace. That is alternating attention. And last, divided attention. It is the ability to respond simultaneously to the two tasks, that you are able to give your time to both the tasks at the same time. That is divided attention. Next, the third and the last component of the primary cognitive capacity is memory. Memory is basically information storage and retrieval. Now, memory processes includes three processes. First is registration and encoding. First of all, we have to register what is going on in the environment or what is being told to us and encode it in our brain. Second is consolidation and storage, processing what has been told and storing it in the correct area. And third is recalling and retrieval of information. When we have to again think about that particular incident, then we will recall it from the storage of our brain and retrieve that information to use it further. Now, information processing model. Whenever we receive an environmental input from the environment, sensory registers are all our basic senses, where brief storage and coding of the sensory stimulus happens. So now, if for example, we have an environmental input that someone came to my room and told me something. So my sensory registers would be, first of all, I look at the person and hear to what he or she is saying. Now, automatically, what we are seeing, what we are listening will be automatically transferred to our short-term memory or the working memory, which will include all the attention processing, and the data will be then stored to the long-term memory, where now when the data is stored in the long-term memory, whenever next time that person will come to the room, I will automatically remember that this person came and told me this thing from my long-term memory, and it will be retrieved through working memory. So that way the data is not lost and we will be able to retrieve what information was stored earlier in our brain. Now we'll come to types of memory. The first type of memory is the immediate memory, that is held in our conscious awareness within the less than 1 minute. That means that this is the memory when someone is talking to you or someone is telling you or giving you command to do something. For example, if a teacher told you that you have to go to this room and sit there and I'll come there and take the class. So that is the immediate memory, that you remember it, that you have to visit this classroom and sit there. This is the immediate memory where you are consciously aware of what you have been told and you are performing it. Short-term or primary memory. It is held temporarily for more than 1 minute. This is the short-term memory where we are able to remember what has been told to us for a period of 1 to 5 minutes. Next is long-term or secondary memory. It involves interval of more than few minutes between the stimulus and the recall. That means if I have told you something right now and I ask the person to repeat it after 30 minutes or after 1 hour or maybe next day, that is long-term memory. That means the data storage, we are retrieving that information from our storage of the brain and utilizing it. Next is working memory. Temporary storage and manipulation of information needed to perform a task. Working memory is that if I have given you multiple commands together, that you have to go to this particular room, take this much data from this particular person, and give it to this particular person and then perform a certain action. That is working memory, that you have been given a temporary storage of tasks that you have to perform and manipulate in your brain to perform a particular given task. Now, recent memory. Recent memory corresponds to the long-term memory, where memory is from hours to months past stimulus. That means recent memory is, for example, we generally ask patients that do they remember when did they last when did they met the accident, or when did the incident of stroke happen. So when we ask the recent history from the patient, we are able to identify whether the recent memory is impaired or not, whether they remember the incidents from the past hours or past months or not. Now, remote memory. This is very long-term memory. For example, the memory from the childhood, whether they remember the incidents from their childhood or not. Episodic memory. It is memory of one's personal history. For example, what did you have in the breakfast? What did you have in the lunch? That is episodic memory. That pertains to a particular episode. Now, last is semantic memory. That is personal knowledge of the world. That means facts. Different facts. What is the capital of India? This is the standard fact that any person would know, and it would remain for every person. Now we'll move on to higher thinking abilities. Now the first component of the higher thinking abilities is problem solving. It is conceptualized as a multi-stage process. Solving any problem is a multiple stage process in which the first task is to identify the problem. Now, when we have a problem at task, now we will first identify the problem. That what is the problem? Now we will define the problem. In defining the problem, we will divide the problem into various components and analyze where exactly the problem is happening. Now, thirdly, we will generate possible solutions. Now we know that we have this particular problem. We will try to generate solutions for that and select which one is the appropriate solution for a particular thing. Fourthly, we will implement the preferred solution. Now, the preferred solution that we have generated out of the list of solutions, we will try and implement it to solve our problem. And lastly, we will evaluate the outcome against the desired goal. That is, we will evaluate whether the outcome that the problem that we were having and the solution that we implied, whether we were able to reach our desired goal or not. Second component in the higher thinking abilities is reasoning. It entails drawing inferences or conclusions from known or assumed facts. That means that there are certain, in our memory, we have already stored certain facts and certain incidents in our memory. Now we will draw inferences from our memories that are stored in the brain and the conclusions that we have learned from the known or the assumed facts. Now the reasoning makes use of four things. First is sequencing, that is sequencing our thought process, then classifying those thoughts into different categories and using deductive and inductive reasoning to apply it. So the first component here is sequencing. That is, we will order the information properly. Sometimes when we are in a situation where we are in a problematic situation, what we do is we will collect our thought, all the train of thoughts. We will order them in a particular sequence. Like for example, if you have lost your phone, you will start thinking about from where all you have visited. You will order your thought process in a particular sequence. That you went to the mall, you took the cab, you went to another shop, then you came home, and now you will start classifying those. Now you have classified those and grouped those ideas according to the characteristics. Now the one classification would be of the mall, one would be of the cab, one would be of the shop, and one would be of the home. So we have sequenced our thoughts. Now we have classified into groups. And now we will go into one particular classification and think about what was done in the mall. Where was I? Where did I went? Then secondly, we will go to the cab. Did I left the phone in the cab? So we will classify our thoughts. Now deductive reasoning. And how will we perform the reasoning is using deductive reasoning and inductive reasoning. So in the deductive reasoning, the thinker is using general information to identify specific facts and principles. That means the reasoning that we are using in this particular example, where we are thinking about where did we went, how did we use the how did we use the phone, where did we kept the phone. This is general information that we had stored in our brain, and now we are using it to identify the specific facts and principles. The second process of reasoning is inductive reasoning. That is where a thinker is given a set of examples and must create a general rule. Now we have a lot of different examples, like while organizing any event, we have the idea that how much personnel you will require, what all resources you will need. So you have a different set of examples already with you, and you have to create your own, you have to provide your own organization skills and create a general rule like how you would want to proceed further. So last concept in the higher thinking abilities is the concept formation. It is the ability to analyze the relationship between objects and their properties. Concept formation could be anything like spatial organization of different objects, or any concept that any social story, any concept that we are going through in our environment. So Solberg and Marty suggested that forming a concept requires an individual identify the critical features of the instances and also determine how those features are interrelated. So to form a particular concept, first of all, we should know what are the critical features. Like while as a therapist, while we create any concept, it is very important for us to know the basics. Like for cognitive assessments or cognitive screenings, one must know that what are the components of cognition, what are the details, how many types of attention are there, how many types of memory are there. When we know the critical features, after that we will move to these are the testing procedures that we can perform. And now we have to interrelate all those features to imply it on our patients. So now we have moved on to metacognitive processes, which includes two components, that is executive functions and self-awareness. Now executive functions are necessary for successful performance of any unstructured multi-step occupational task and roles. Any task which we are performing in our daily life, or we are conducting any task to execute any purposive function, that requires executive function. So now for successfully performing that task, we will go through multi-step processes, which are always unstructured, because we are structuring those processes while we are executing a task. So now executive functions have 4 components. First is volitional behavior, second planning, third purposive action, and fourth effective performance. Now volitional behavior. Volition and goal form. Volitional behavior is basically self-awareness. We are aware of a particular action that we have to take, and now we are self-aware that what all will we need. We have to initiate the process, and now we have that motivation that we need to do this particular thing. Now second step would be planning. Now we have to we should be able to plan how to execute that particular task, how to conceptualize, how to arrange all the things, how to organize it, what to choose and what not to choose, and how to develop a plan. So this volitional behavior was that we are motivated and initiated a particular task. Now we will plan it, we will conceptualize it, we will change, we will organize the steps, and we will develop a plan. Now to execute that plan, we'll have to do purposive action. That means we have to implement the plan now. And we will implement that plan using the primary cognitive capacities and the higher thinking abilities. Now, after purposive action, that means that you have executed your plan, you have executed the action. Now we have to see effective performance. That means that the action that we did, what is the effect of that performance? We'll check the quality of the performance, we'll check the quality control, how the self-correction was done or not done, how was monitoring of that action done or not done, whether we were able to manage the time or not. We will see all this. So these are the 4 components of the executive function, that is volitional behavior, planning, purposive action, and effective performance. Next, we move on to self-awareness. Self-awareness is the ability to process information about the self and compare it to the long-standing self-evaluation. That means we already know about ourselves and we are able to process information about ourselves and compare it to the previous version of ourselves, that we are self-aware that how we will perform a particular task and what are the changes going on inside us. So now self-awareness has 2 primary tendencies. One is appreciation of the personal attributes such as physical and cognitive strengths and weaknesses. That means one knows that, oh, now my weight is increasing. Now I am having this particular change in my body. Or now I know that I am strong in this particular concept, but I'm not that strong in the another concept. So that is appreciation of the personal attributes, knowing your own strengths and weaknesses. Second concept is initiation of compensatory strategies in response to no personal attributes. Now, secondly, what we will do, now we first know that this is what I am weak in and this is what I am good in. So I will now initiate the compensatory strategies or the strategies in response to the attributes. Now, for example, I know that I am good in a particular thing, but I'm weak in this particular thing. So the thing that I am weak in, I will try to learn more about it. I will try to read about it and I will try to grow in that particular area. So that is initiation of the compensatory strategies. Now self-awareness is divided into 3 types or 3 levels. The first one is anticipatory awareness. Anticipatory awareness is ability to anticipate that a problem will occur due to result of a particular action or impairment. That means when we are in a particular situation, we are able to anticipate, we are able to identify that this could lead to a particular problem in the near future. So we are able to, like for example, if we are at home and we have that smell of gas, then we identify that there must be a gas leak or there must be that gas is on. So we are able to anticipate the problem and react to it and take an action. We'll go and look for the gas, whether the gas stove was on or not. We'll close it. Then second is emergent awareness. That is ability to recognize the problem while it is happening. While we are in a particular situation, whether there is some problem or not, we are able to identify it. That is emergent awareness, which is identifying the problem immediately when it is happening. And the last is intellectual awareness. Intellectual awareness is ability to understand the problem at some level and identify that a function has been impaired. Now we know, for example, if someone has a fracture, they know that this is a problem and I have to submit this work. So I have to pre-plan the things. How will I particularly execute that work? Because I am already aware about the problem. That is intellectual awareness. Now, these were the components of the cognition that we usually screen and during the cognitive assessments. These 3, the components are divided into 3 categories again: primary cognitive capacities, higher thinking abilities, and metacognitive processes. Now we will look at how these components might impact our occupational performance. So the first factor is the client factors or the body functions. Now, in the body functions, we have specific mental functions and global mental functions. Among specific mental functions, it includes higher level cognitive functions, that is judgment, concept formation, executive function, metacognition, and cognitive flexibility and insight. Whether the one is aware about all these, whether the one is able to judge whether what is right and what is wrong, he or she is able to identify what is the concept behind a particular thing, execute the actions, and there is flexibility in the cognitive processes. The second is attention, that we have already discussed. We have 4 types of attention: sustained attention, selective attention, alternating, and divided attention. Third is memory, that is short-term memory, long-term memory, and working memory, as discussed earlier. Then perception, discrimination of sensations, that is we are able to perceive, we are able to take all the input from the environment and discriminate among those sensations and process the information and retrieve it from our storage to implement the action. Now, last is thought, that is control and content of thought, awareness of reality versus delusions, logical and coherent thought. We have to know that how much control we have to give to a particular thought and what is the content of our thought. We have to be aware of what is real and what is not. And we have to be logical about behind our actions. We have to give logic behind our actions of what we are doing. Next is global mental functions. Global mental functions include consciousness, that is state of awareness and alertness, how aware and alert we are with respect to our environment or surroundings. Second is orientation, again how oriented we are to the time, place, person, self and others. Then last is temperament and personality. Personality could be in different forms like extroversion, introversion, agreeableness, conscientiousness, emotional stability is there or not, whether we are open to new experiences or not, how much self-control we have over our expression, how confidently we are doing a particular task, how motivated we are. Now, these were the client factors or the body functions that could be affected if the cognition is impaired. Now, performance skills. Performance skills mostly are affected in the process skills that we observed in a person. That means how the person selects or interacts with the tools or the materials provided to him, how he or she is using that particular task, then how the individual is carrying out the actions and the steps, how they are processing the information that they have been given and executing the actions. And last is how they are able to modify the performance when the problem is encountered. If, for example, we give patients different situations, we check in different simulated situations that how the patient is able to perform the task. That is analyzing the performance skills and analyzing in the first area, we have analyzed the components and tested different components. Now we will analyze the performance of the person in those particular components. Last is performance in various areas of occupation. Now, according to occupational therapy practice framework, we have these many areas of occupation where we will analyze that how the cognitive impairment is affecting the occupational performance in these areas of occupation. So these are activities of daily living, instrumental activities of daily living, education, work, play, leisure, rest and sleep, and social participation. Now, cognitive assessment. Why do we need to perform cognitive assessment and what is the purpose of cognitive assessment? So the first is to measure the baseline progress and the outcome status to identify whether our patient is having any cognitive deficit or not. And if we find out that on the screening there might be the chance of cognitive deficit, we would like to document it. So we will measure the baseline score and we will give intervention and check the progress score, like how much progress the patient has done through our intervention and what is the outcome. Second is to understand the patient's cognitive strengths and weaknesses and capacity for strategy use in order to plan intervention. It is very important as a therapist for us to understand what is the cognitive strength of the patient, how much and to what level they are able to understand our commands, how much they can remember, so that we can accordingly strategize our intervention plan. Third is to estimate the patient's ability to safely perform everyday activities. The main goal as an occupational therapist is to make the client independent in his daily functioning. So it is very important for us to estimate what is the cognitive ability of my client so that he or she is able to perform his daily function tasks safely and not injure himself or herself. Now, components of cognitive assessment. We have already read these components in the previous slides. Now we will discuss how to test it. First is orientation. Orientation, we will try to ask the patient what is the time, what is the date, what is the day, who is the person who he has come with, who am I. We will try to understand whether the person is oriented to himself, to the environment, and to the others. Now, second is attention. Now we have seen there are 4 types of attention. We can test it through very simple tests. The first is random letter test. In the random letter test, we will speak the alphabet in a random order with 1 word per second speed, and we will ask the patient that we will give the patient a particular word. For example, B. Now we will randomly speak different letters D, F, B, L, B at the speed of one letter per second, and we will ask the patient to tap on the letter B. Now we will have to see how much the patient was able to perform the task accurately. So we will see 3 things in this test. First is omission, commission, and perseveration. So the omission are the B's where he was not able to indicate. It was the number of letter B that he was not able to indicate, or he failed to indicate. He was not able to tap. Second is commission. That is the wrong letters. That he was tapping on letter D. For example, he was tapping on letter E. That comes under commission. That is the wrong indication. And last is perseveration. That is the ability that he was not able to stop the tap. Like, for example, right now I said B, then I moved on to D, then E. So the patient was not able to stop the tap. That is perseveration. So in this random letter test, we will check the error into 3 categories. That is omission, commission, and perseveration. Now, selective attention. For selective attention, we have Stroop test. In the Stroop test, you can see that I have mentioned different color. It has mentioned different colors which are written with another color. So we will ask the patient to read the color. For example, the first one is blue. So what color is this? This is what is written here is blue. But with which color it is written is red. So we will give the patient our slide and ask them to read the word and tell the color with which it is written. This is Stroop test for selective attention. Now, alternating attention, we have digit repetition test. Again, in the digit repetition test, we will repeat the digits at the speed of one digit per second, which will be in a random order. Now, if the patient is able to repeat till 5 to 7 digits, like we have given a series of 10 digits to the patient, and the patient is able to repeat it till 7 digits, that is considered a normal range. But if the patient is unable to repeat until 5 digits, like less than 5 digits are repeated, that means there is some form of deficit in the alternating attention. And if the patient is unable to perform this test twice, then we stop the test because it is not available. Now, last is divided attention, that is reverse digit span test. In the reverse digit span test, we will do serial addition or subtraction. We will ask the patient to subtract from 100, subtract 7 from 100, and we will ask the patient to subtract 7 from 100 and move backwards. So that is reverse digit span test. Now memory. For memory, we will do recall test. We will ask the patient to remember 5 words and ask them to repeat it immediately. If the patient is able to repeat immediately all the words, that is immediate memory. Now we will ask the patient to repeat those 5 words after 1 to 3 minutes. If the patient is able to repeat them after 1 to 3 minutes, that is short-term memory. And now we will ask the patient to repeat those words after 10 to 30 minutes, and that is long-term memory. For problem solving, we can give the patient various maybe simple mathematical calculations or any daily life situation, and how the person will solve that particular situation to identify all the concept formations, reasoning, and problem solving skills. For self-awareness, again, we have to give different situations to the patient and ask whether he or she is self-aware about the particular situation, about the particular problem or not. And for the executive function, we can ask the patient to perform any daily living task like eating food, and we can identify whether the patient is able to execute the task in a proper manner or not. So now the cognitive functional performance. While we assess cognitive functional performance, we are dividing the assessment into three categories. The first is dynamic assessment, second is informal observation, and the third is performance-based assessment. In the dynamic assessment, we use dynamic assessment through the uses of cues and feedback, where we try to understand how to elicit the patient's best performance through providing different cues and feedback. Like there is one questionnaire which is dynamic interactional assessment, which includes question about awareness, whether the patient is aware about the self, patient is aware about the environment, and the patient is aware about others or not. The second task is cueing and task grading. We will give the patient cues and we'll give the patient tasks, and we will provide cues and mediators so that the patient is able to conclude the task. And last is strategy investigation, and we will try to find and investigate what strategy or what intervention we can plan for the particular patient. So I think Lotka scale, that is Levenstein's occupational therapy cognitive assessment, most of us are aware about. That is a form of dynamic assessment where we are using cueing and task grading to analyze the cognitive performance of our client and then planning the strategies or the interventions for the client. Second is informal observation. Informal observation is again a part of screening that we do on a regular basis whenever the patient comes to us. That is, we are able to make hypotheses about the strengths and abilities of the client and identify the domains which might be affected. And informal observations are mostly subjective. That means it might vary from therapist to therapist, and these are easily influenced. That means the observations could be influenced by the decisions of the others. Last is performance-based assessment. It includes performance of a task. That means we will give the task to a patient and ask them to perform it, and we'll give simulated tasks for the daily living activities, and we will see how the patient is executing that particular task. So this is a functional assessment. So now we have divided our functional performance into three categories. Dynamic assessment, where we are providing cues and we are grading the cognitive capacity of the client. Informal observations, through which we are screening and identifying the domains where the problem might be. And performance-based tasks, where we are assessing the performance and its impact on the occupation. Now, screening tests. We have certain standardized screening tests that are used clinically. One is mini-mental state examination, and another is Montreal cognitive assessment. These two are the most commonly used screening cognitive assessments in our field. These are their formats. So the takeaway points from this presentation are the cognition and its components. We have discussed the cognition is divided into three broad areas. One is primary cognitive capacities, second is higher thinking abilities, and third are metacognitive processes. Now, how these components influences our occupational performance. What are the components that are affected, like body functions, that is specific mental functions and global mental functions, and how it will impact our occupational performance, and what is the importance of assessing cognition and how we can screen different cognitive components. Thank you. Any questions?
I'm sorry, I forgot to unmute myself. Okay, thank you, Agrima, for the wonderful session. Is there any queries regarding the session? There is one, Agrima. Ma'am, how we will assess any tools or any standardized tests?
We will be discussing the standardized test tomorrow.
Okay. Can you explain dynamic assessment again? For you all who are like here to get the information, they can go to the YouTube link. There will be the video saved, and you can have all the information regarding anything, any point you have missed during the Agrima session. You can check out there. Please explain the test again. I think we are not having any other questions. We can leave the meeting. We'll meet again tomorrow by the same time. And I request everyone to have to fill the which one was feedback form that will be shared into the WhatsApp group. That will be the same also. Anything else?